session is on wound assessment and documentation. We've already talked about the process of wound healing. We've talked about the systemic factors that have to be addressed. We've talked about the importance of identifying etiologic factors. Now we're going to pull that together. We're going to talk about when you get consulted for a patient, you go in, you've got to assess etiology of the wound, you've got to assess the factors impacting healing, but you also have to do an in-depth assessment of the wound itself, and that's going to provide you with the data you need to put together an appropriate wound management plan in terms of topical therapy. So those are the things we're going to be talking about. As we just said, in-depth comprehensive assessment is critical because that's going to tell you everything you need to know about the wound, or the most important things about the wound, so that you can put together a comprehensive management plan. If you do a good job of wound assessment and you document what you see and what your plans are, it goes a long way toward helping to protect your agency and you against litigation. Now, there's a lot of errors that you will see when you look at the kind of documentation on most charts related to wound status. You'll find that there are many inconsistencies. You'll find wounds that change dimensions radically from one Monday to the next and then back again. You'll find major inconsistencies in wound staging. You'll find gaps in identification of wound location. These are things you want to be very alert to when you look at what's going on in your agency. Because as the wound care specialist, as the person who's driving the wound care program, one of the things you want to do is assess what's happening at baseline in terms of wound assessment and documentation. And then you want to provide in-services and guidance to your staff so that you bring wound assessment and documentation to the level where it needs to be. Now, in doing your initial assessment, as we just referenced, this is you walking in, you haven't seen this patient or this wound before, and so you've got to determine everything. You've got to determine etiologic factors so you can correct them. You've got to look at systemic factors like nutritional status, glycemic control, is the patient on steroids. You've got to determine wound status so that you can put together appropriate topical therapy. And you want to find out how this wound is affecting this patient's quality of life. That's really important because many times patients tell us that their #1 goals are control of odor, pain, drainage, so that they can get on with their lives. We're so focused on wound healing, but we don't want to forget that that wound is affecting a patient in his or her family. Also, once we hear what that patient's goals are, then we can work together to come up with a management plan where hopefully we're both on the same page. Now, when you do follow-up assessment, you're focused differently. You're not doing your comprehensive, in-depth assessment on follow-up. You're primarily looking at wound dimensions, the status of the wound bed, the volume of exudate, things that would change your approach to topical therapy, and the parameters that tell you whether or not your wound management plan is working. When you're doing follow-up assessment, you're always looking at the wound today, and then you're looking back. What did it look like last week? Do my findings today, as compared to my documentation from last week, represent progress in wound healing? Do I see deterioration? Has my wound plateaued? The answer to that question, major implications for management. If I'm on track, I'm basically going to continue with my present plan. I'll tweak my topical therapy if there's been a change in exudate, change in wound depth. If my wound has plateaued, it's time for me to start looking at what's going on. We'll talk more about that in our next class. Could it be heavy bacterial loads? Has something changed about nutritional status? If the wound's deteriorated, almost always, it means that you have surface wound infection. But again, we'll come back to that. So in looking at priority #1, what caused this wound? Your major clues are location. Location tells you so much. That's true of trunk wounds, it's true of lower extremity wounds. The depth and the contours also tell you a lot. So we've already talked about top-down versus bottom-up injury. If I have a superficial wound on the trunk, I know that it's most likely due to some combination of moisture and friction. If I have a deep wound over a bony prominence, I know it's caused by some combination of pressure and shear. Leg ulcers also, location tells you a lot. The status of the wound base, the volume of the exudate. We haven't covered leg ulcers yet. We'll be covering that later, so I'm not going to get into that. So here's just a quick summary. If you have a wound that's caused by pressure alone, as we have discussed in previous classes, that wound is going to be located over or immediately adjacent to a bony prominence. Most commonly it's round or slightly oval. You typically have either no undermining or minimal undermining, usually no tunneling. In contrast, if the wound's caused by a combination of pressure and shear, it's very common to have elongation of the wound, undermining is common, tunneling is common. But again, it's usually over a bony prominence. Now, friction injuries are different, and of course, in many settings, this wound would be misclassified as a pressure ulcer. We've talked about that before. But we know it's not a pressure ulcer because, first of all, it's not over a bony prominence, it's over a fleshy surface. Secondly, it's extremely superficial, and there's no evidence of tissue necrosis, tissue ischemia. The one area that's adjacent to a bony prominence, not over it, is the one on the left, trochanter. But again, is it over the bony prominence? No. It is adjacent. If you could not rule out pressure, then you might label it as a pressure ulcer. But if you knew that this wound occurred as a result of friction, you would classify it as a friction injury. And then you've got your moisture lesions. Now, on top, of course, you've got incontinence-associated dermatitis, caused by exposure to urine and liquid stool and complicated by candidiasis. On the bottom, you've got intertriginous dermatitis, that linear break in the skin that occurs at the base of a skin fold. So it's going to be at the base of a pannus, underneath the breast, in the groin fold, or in the natal cleft. I'm going to skip past that. We're going to come back to that when we talk about leg ulcers. The second thing I want to look at, so goal number one, do I know what caused this wound? That's the most important question on my first visit. What caused this wound? Because my management plan begins with correction of etiologic factors. My second question is, can this patient heal this wound? Does the patient have the systemic support needed to heal the wound? That means I've got to look at nutritional status. I've got to ask about weight trends. I've got to look at the patient. I've got to look at labs. I might have to order a calorie count or do a 24-hour recall, diet intake recall. I've got to look at my glycemic levels. Is this patient a known diabetic? What's their A1C? What are their glucose levels running? Even if your patient's not a known diabetic, check glucose levels, because sometimes the stress of illness, surgery, hospitalization will result in elevated glucose levels. I want to look at my med sheet. I want to see if this patient's on steroids, and if so, what dose. I want to make sure the patient's not getting chemo or high-dose non-steroidal anti-inflammatories. I definitely want to assess perfusion to the wound bed. Now, as we've said in the past, perfusion is usually not an issue for trunk wounds, but it's frequently an issue for lower extremity wounds. When I'm checking my labs, though, I should look at my H&H to be sure that I'm not dealing with significant anemia. And we've talked about we want to know what the patient's goals are, because the patient's what matters, or who matters. You've probably heard the term that we want to take care of the whole patient, not the hole in the patient. And actually, that's a kind of nice phrase, because it just reminds us that meeting the patient's goals is a key aspect of our care. and that getting the wound healed is not the only thing that matters, that we have to also address quality of life issues, which does come down to pain, to issues regarding cost of care, absence from work, all of those things. Now, in doing our follow-up assessment, as we've said, we've already done that comprehensive workup, so we already know that we're dealing with a pressure ulcer on the right trochanter in a patient who is nutritionally compromised, diabetic with poorly controlled glucose levels, and that the patient's major concerns are pain. Now we're going to look at the wound itself, and when we're doing our follow-up assessment, we're primarily focused on changes in wound status. We're still alert to everything else that's going on. So if at my initial assessment I identified that the patient was nutritionally compromised and I pulled in the nutritional support team and they're working with the patient, it's very relevant for me to track what's going on nutritionally. If I identified that the patient had poor glucose control and internal medicine's been working with meds and diet to try to tighten glucose control, I'm going to go back to see where we're to with that. Pain's a major consideration for this patient. Yes, I'm going to follow up with that patient. How's it going with pain? How much pain are you having? How well is it controlled? And we're going to come back to specific things we want to assess about pain. And looking at the ulcer itself, my follow-up assessment is going to focus on parameters that show me progress in wound healing. So I'm going to look at dimensions. I'm going to look at depth. I'm going to look at the quality of tissue in the wound bed. I'm also going to look at things that would change my approach to therapy. We've talked about volume of exudate. That's a key determining factor when we select dressings. I'm also going to be very alert to any signs of surface infection, anything that would change my treatment plan. Okay, so now let's focus on the wound itself. What are the critical parameters? Well, location is critical. It's critical for several reasons. First of all, from a regulatory legal standpoint, you've got to identify where that wound is. Certainly for patients who have more than one wound, particularly important to know, are you talking about the right trochanter or the left trochanter, the medial malleolus or the lateral malleolus. So absolutely critical to get location right. Remember that when you're documenting location, you want to use anatomically correct terms. So if the wound is over a bony prominence, you use the name of the underlying bony prominence. For example, this wound on top is over the left trochanter. You would not say hip. You would say left trochanter. If it's in the natal cleft, you want to say natal cleft, not gluteal fold, because gluteal fold actually refers to the point at which the upper thigh meets the buttock. So be careful to use correct terms. Make sure your staff knows correct terms. You might have to post little drawings that show them. Okay, if it's here, you call it sacrococcygeal. If it's here, you call it ischial. If it's here, you call it trochanteric. Also, location has implications for management. If you have a trunk wound, you know that you're usually going to need an adhesive dressing, something that will stay in place. In contrast, if it's an extremity wound, you can frequently secure it with wrap gauze. So location, very important from a legal, regulatory perspective, but also important in terms of looking at therapy. Dimensions and depth, very critical. You probably are going to want to have in-services with your staff where you give them wounds and make sure that they are measuring at the correct points. One of the things that makes it confusing is that wound care clinicians have used different approaches. Probably the most classic approach is to use length as 12 to 6, width as 9 to 3. So top to bottom, side to side. And those dimensions should be perpendicular to each other. In the past, though, we sometimes used a different approach. Sometimes we would measure point of greatest length times point of greatest width times point of greatest depth. And I put this slide here to illustrate the difference. If I use greatest length, I would be measuring here to here. If I measured greatest width, I would probably be measuring here to here. But the current recommendation from National Pressure Ulcer Advisory Panel is to measure top to toe, okay, or 12 to 6. So I'm going to look for my longest dimension from a 12 to 6 orientation, and that is probably going to be right in here. And then I'm going to look for my longest dimension from a side-to-side orientation, which is going to be right here. So 12 to 6, 9 to 3, perpendicular. Then you find the point of greatest depth, and you put your cotton-tipped applicator into the wound at the point of greatest depth, grasp it at skin level, then hold it next to a measuring device to get depth. Now, we know that getting accurate dimensions is affected by how the patient's positioned. So you want to position the patient exactly the same every time you do your measurements. And you want to be very consistent in doing your measurements. Otherwise, you're not going to be able to accurately track progress in wound healing. One thing that a lot of clinicians do is they'll make a little drawing, and then they'll put arrows to indicate the point at which measurements are being taken. And that's a great approach because it builds in consistency. So greatest length, okay, from a head to toe orientation, 12 to 6 orientation. Greatest width from a side to side, 9 to 3 orientation, and point of greatest depth. Now you're going to take either a cotton-tipped applicator, or if you have very narrow tunnels, you want to use a surgical probe or a little disposable suction catheter or urethral catheter, because you want to make sure that you know exactly how much tissue damage there is. You never want to miss a tunnel. You never want to miss an undermined area. Again, for two reasons. One is you will fail to capture the true extent of the wound if you fail to capture tunnels and undermined areas. And then you have an incorrect baseline. Even more importantly, when you have a tunnel, when you have undermined areas, then those are points around the wound where fluid will accumulate. And a key element of effective therapy is to wick fluid out of tunnels, to wick fluid from undermined areas. So always critical to take the time to explore your wound edges. Now, when you have tunneled or undermined areas, you document two parameters: location by clock face, with the patient's head representing 12 o'clock, and extension from the wound edge. So in this case, and we do not use forceps, so please ignore that. But in this case, the patient has undermining from 1 o'clock all the way over to 5 o'clock. So I'd say undermining 1 o'clock to 5 o'clock. And then I'd have to use my little probe or cotton-tipped applicator and see how far from the wound edge that undermined area extended. So I would put my little probe in until it came to the end of the undermined area. I would grasp it at wound edge and hold it against my measuring device. Many times, the extension of undermining, the extent to which you have undermining varies. So maybe at 2 o'clock it undermines to 2 centimeters, but at 5 o'clock it undermines to 6. So you would say undermining 1 o'clock to 5 o'clock, ranging from 2 centimeters at 2 o'clock to 6 centimeters at 5 o'clock. Same thing with the tunnel. If you had a very narrow tunnel, that's when you want to be very careful, because if you have a very narrow tunnel, like something like 0.2 centimeters, and you put your cotton-tipped applicator up in that tunnel, you're likely to leave the cotton tip behind. You never want to do that. So when you're concerned about leaving something behind in the process of measuring a very narrow tunnel, pick something safe. That would not be the wooden end of the cotton tipped applicator, which I'm sure you've seen people do. It would be either a stainless steel surgical probe or, as I said, a little polyethylene catheter. The little female catheters or suction catheters are very safe in that situation. Now, the next thing you want to look at is the status of the wound bed. What kind of tissue do you have in the wound bed? You don't just want to document color. Color does not tell you what you really need to know. What you really want to know is where is this wound to in that wound healing trajectory. Is the wound in the inflammatory phase, as evidenced by slough or eschar, or both? Is the wound at the end of the inflammatory phase, but not yet actively proliferating? That would be a clean wound bed without granulation tissue. Or is the wound actively granulating or epithelializing, which means the wound is doing well and is in the proliferative phase? So here, on top, you saw this wound earlier. We have a wound that's doing well. It's granulating effectively. So that's exactly what I want to see. Now, I am going to look back to see how does the wound status this week compare to the wound status last week, because I can see, and looking at this, I have good granulation tissue here and here. This little center area and toward the right is clean, but you have just a few little patches of granulation tissue. If I look back and it said that last week the wound was 20% granulating, I'm like, okay, I'm making really good progress, because this week I think it's at least 50 to 60% granulating. If last week it was 100% granulating, then I'm a little concerned because I've had deterioration. And in this wound, of course, you see a mixture. So we have granulation tissue, we have advancing epithelium, and we also have an area that represents about 20% of the wound that still has a thin layer of slough, plus an area that represents about 10% of the wound that's been cauterized with silver nitrate. But if you're seeing granulation tissue and or epithelial resurfacing, and if the percentage of the wound that's granulating or resurfacing is greater than it was last week, then this wound is on track and you can feel good. Eschar, of course, easy to identify. And if you look at the wound on top, you have a combination of eschar and then an area of the wound that is clean but not yet granulating. I would guesstimate that this is about 45% that's eschar and about 55% that's clean, non-granulating. And I do want to point out that you should guesstimate the percentage of the wound bed that has granulation tissue versus clean, non-granulating versus slough or eschar. Because if I'm coming behind you and you just write down eschar, clean, non-granulating, granulating, and then I'm seeing the same thing, I don't know if it's better or worse. So that guesstimated percentage is very helpful. It is true that it's a guesstimate, but a guesstimate is better than nothing. And one way that people sometimes do the guesstimate is to visualize the wound as being in 4 quadrants. And if I did that, this quadrant's almost all necrotic tissue. So I would count that as 25% necrotic. And this quadrant's partially, so maybe 10%. And then these 2 quadrants, very little, so maybe 5%. So you can get to at least a ballpark figure as to how much of the wound has slough, how much of the wound has eschar, how much of the wound is clean, non-granulating, how much of the wound is actively granulating. Now, look again at this wound. You've seen this wound previously. This is that high amputation. The wound is clean, but notice there is no granulation tissue. There is no area of the wound that has that irregular berry-like surface. And it's very, very important to distinguish accurately between a wound that is clean but not granulating and a wound that's actively granulating. If you say it's granulating, you say it's healing. it's in the proliferative phase, it's on track. If that wound is clean but it's not granulating, it may be stuck, and you want to recognize that. So very important to differentiate. Slough and eschar, pretty easy. So again, if we look at the wound on top and we guesstimate the amount of the wound covered with slough and the amount of the wound that's clean, non-granulating, we would probably say somewhere between 30 and 40% of slough, 60 to 70% clean, non-granulating. This one's easy, 100% eschar. We talked in our class on wound healing about the importance of assessing the wound edges because, as you know, it takes open wound edges in order to get epithelial resurfacing, the final phase or the final aspect of the proliferative phase. So we're always looking at our wound edges. And I want you to look at the wound on top because you can see open wound edges on one side, closed wound edges on the other side. So if you follow my pen, you can see that red, wet, open edge from about 7 o'clock to 12 o'clock that looks very much like a paper cut. And then look from 12 o'clock to 4 o'clock, where there is no red, wet edge. You go from dry, intact skin to wound bed. So look very carefully at your wound edges. When you get into clinicals, it will be easier to appreciate open versus closed wound edges. This one you saw earlier, again, open on the inferior aspect, closed on the superior aspect. And you know, major implications if you find closed wound edges, you're going to have to intervene to get that wound to heal. You want to look at the status of the surrounding skin. So there's many things that you're alert to. First of all, you want to pick up on any evidence of invasive infection, cellulitis. Sometimes that's very easy because in someone with normal perfusion, normal immune response, if they have a soft tissue infection, the tissue is going to be red, indurated, hot. They're going to have a lot of pain, probably a lot of drainage. So those patients, very easy to identify. You would never miss it. But look at this patient. It doesn't immediately jump out at you that you have infection of the surrounding tissue, but when you look very carefully, yes, you can see that there's erythema all the way around this wound edge. It's faint, but it's definitely there. And if you palpate, you'll find that you have slight induration. Is that significant? And yes, it's very significant because this patient has peripheral arterial disease, marked reduction in blood flow to the wound bed, also has poorly controlled diabetes, so a damped down immune response. So your take-home message is you actively look for any signs of wound infection every time you do a wound assessment. And in a patient with diminished perfusion or compromised immune function, faint erythema, slight induration is just as significant as bright red erythema, rock hard induration in milieu. You're also going to be alert to things like callus formation that would need to be pared down, maceration, which tells you you need to do a better job of protecting the surrounding skin and absorbing the exudate, candidiasis, a yeast rash, which needs to be treated. So you always inspect the peri-wound skin, and if there are any problems, if there's any pathology involving the peri-wound skin, you're going to add that to your treatment plan. Exudate, of course, a critical factor in wound assessment. This is actually one of the things that usually does get assessed relatively well. You want to know volume, and that is a subjective evaluation. If you have to soak the dressing off, that is going to be minimal or no exudate. If the dressing separates readily, but it's been in place for 48 hours and there's no pooled exudate, then that would be a moderate amount of exudate. Heavy exudate, of course, would be if you had strike through, if you had pooled drainage within the wound bed, if you were having to change the dressing twice a day. So you estimate volume. You want to describe both color and clarity. So is it serous, clear yellow? Is it purulent, kind of a thick yellow-white? Is there odor? Exudate, of course, is important because if you have increasing volumes of exudate, if you have very malodorous exudate, if you have very purulent exudate, all of those can be indicators of infection. Also critical because volume of exudate is a primary determining factor in dressing selection. If you have a very wet wound, you need a highly absorptive dressing. If you have a very dry wound, you need a hydrated dressing. And if you have a wound with a little bit of exudate, then you need a dressing that has very controlled, low-level absorption. We'll spend a lot of time on that. We talked about pain matters. So you want to, when you're looking at your assessment forms, your flow sheets for wound assessment, make sure that pain is on there, wound-related pain. Two types of pain, procedural pain and baseline pain. Procedural pain we can frequently manage with topical anesthetics like lidocaine, xylocaine, Emla, and by modifying our dressings and our wound care approach, being very gentle, using dressings that do not cause stripping, do not stick to the wound bed, those kinds of things. Pre-medication. All of those things very effective for procedural pain. But if your patient has baseline pain, pain that's waking them up at night or keeping them awake, pain that's interfering with their activities of daily living, those patients are going to require around-the-clock medication. Some patients can be managed with topical agents like sustained-release lidocaine patches, but many will require oral medications. Talk more about that when we talk about wound management. Okay, here we go, staging. I left this to last because I wanted to say staging is not the most important aspect of wound assessment, even though we spend a lot of time talking about staging. Some of us wish we had never ever started this whole staging routine in the first place. And our current staging system is being challenged. There was an excellent article written in Advances in Skin and Wound Care, end of 2011, challenging our current staging system, asking if our current staging system accurately reflects the pathology of pressure ulcer development and progression. I'll share some of that as we go along. So things to know about staging. First of all, you should use staging only for wounds that are caused by pressure. You do not stage incontinence-associated dermatitis. You don't stage intertriginous dermatitis. You don't stage skin tears. You stage wounds caused by pressure, okay? And secondly, it's harder than it sounds. You say, oh, well, how hard can it be? You've got stage 1, 2, 3, 4, unstageable, and suspected deep tissue injury. Can't be that hard. In fact, in some agencies, they're trying to teach the entire staff to stage. But if you've been responsible for staging, you know it's not always so clear-cut. It's frequently very difficult. And if you go into an agency where everyone's staging, many times the majority of the documentation is incorrect. Now, stage 1, for people with light colored skin and medium brown skin and Asian skin, Hispanic skin, stage 1 is pretty easy because you have intact skin, but you have discoloration. And fair skin is going to be erythema. And light to medium brown skin, it'll look erythematous. Sometimes in darker skin, it'll look just darker than the intact skin. To palpation, you might feel some degree of fluctuance or induration or heat. Most of the time, it is non-blanchable. So stage 1 means intact skin, but definite changes in skin color and in palpatory findings that indicate that there's an underlying inflammatory response causing prolonged dilatation. Stage 1 is very difficult to detect in patients with very darkly pigmented skin. Patients with blue-black skin, it's impossible to see it. So you're going to be dependent on palpation. Stage 1, always you have intact skin. Always there's some color change if you can appreciate it, and usually some changes to palpation as well. Stage 1 is important to detect because this is our window for intervention. If we intervene promptly and appropriately for stage 1 lesions, they typically do not progress. Deep tissue injury. We talked about this under our class on pathology. This is where you have deep discoloration. It's a purple, black discoloration. It looks like a deep bruise under intact skin. This signifies that there has been significant damage to the deep tissues. There's some thinking that this deep purple discoloration might reflect necrosis of underlying tissues or may reflect disruption of blood vessels and leakage of blood out into the tissues. The significance about deep tissue injury or suspected deep tissue injury is that even if you do everything right, a lot of these wounds progress to full thickness ulcers. So suspected deep tissue injury, very different than stage 1. Stage 1, we expect it to resolve. If you have a stage 1 that deteriorates, they're going to look very critically at the care you provided. In contrast with the suspected deep tissue injury, we know that when it's initially identified, which is sometimes after surgery or after several hours at interventional radiology or at dialysis, the damage has been done. And now what we have to do is prevent further damage and wait for it to declare itself, for it to demarcate so we can see how bad the damage is. Stage 2, lots of controversy about stage 2. Current thinking is that stage 2 lesions practically always, if not always, represent top-down injuries caused by friction or moisture or a combination. Many clinicians believe there is no such thing as a stage 2 pressure ulcer. So this is an area of controversy and unresolved questions. On the staging system as it exists at this point in time, stage 2 lesions are defined as partial thickness skin loss. You're going to have a superficial lesion. It's going to present with viable tissue in the wound bed, so you either have a red-pink wound bed or as an open or ruptured blister. So both of these would be classified as stage 2s, but I can tell you this was not a pressure ulcer. This was caused by friction and moisture. This was not a pressure ulcer. This was not a pressure ulcer. So just be aware. I wish I had questions. I can just share, I wish I had answers. I don't. I can just share the current state of confusion. Stage 3, by definition, extends through the skin layers into the fat. So most stage 3 lesions would be shallow craters with yellow-pink adipose tissue in the base. With the stage 3 lesion, you could have some slough because now you're down to the adipose tissue, and if some of that adipose tissue was necrotic, you could have slough in the wound bed. You might have some tunneling or undermining. Again, there's controversy here. A lot of the stage 3 lesions I have seen were actually traumatic lesions that deteriorated. For example, this was not a pressure ulcer. This was a patient with type 2 diabetes, poorly controlled, severe sensory neuropathy, had a very rough area in his shoe and a little pebble got caught. And he started out in the morning with intact skin, and at the end of the day, he had this open wound, so it wasn't pressure. But a stage 3 pressure ulcer would look like this. I didn't have a stage 3 pressure ulcer, so that's why I'm using this. Now, the biggest challenge for most clinicians in staging is differentiating between a stage 2 and a stage 3. Stage 1, not hard unless they have very darkly pigmented skin. Deep tissue injury, usually not hard, very easy to identify. Stage 4 and unstageable, not hard. But stage 2 versus stage 3, yes, it can be very challenging. because both of these are relatively shallow wounds, and sometimes it's very hard to differentiate between a lesion that extends into the dermis and a lesion that extends just past the dermis into the fat. So of course, if this is stage 2, it's going to be confined to the skin layers. It will stop above the base of the hair follicles. And what you'll see in that wound bed will be that pale dermis that looks white. And you should see distinct little red patches. Each little red patch represents that basement membrane lining a hair follicle. Here's the stage 2. Stage 3, deeper, goes all the way down to the fat. These are some things that sometimes help people, is that with stage 2, you either have a bright red wound bed, like you have here, where just the epidermis has been removed, and you're looking at that reproductive layer, or you have distinct little red islets throughout the wound bed, look like red goosebumps. And I know it's really hard to see on this PowerPoint. It's easier to see it on a slide, and I do have the slide, and I'll show you when you come on site. Stage 2, you never have slough or eschar. Never, because slough represents dead fat, and stage 2 does not extend to the fat. Okay? And no tunneling or undermining. Now, stage 3, you have a definite crater formation. Your tissue's more yellow-pink, looks kind of like pink rice cakes. No distinct epithelial islets. Okay, just a kind of a rice cake effect that's yellow-pink. And again, you can have slough or tunneling. Stage 4, straightforward. Stage 4 lesions extend to the muscle or the bone or the joint. If you can identify muscle, tendon, ligament, joint, bone in the wound bed, it's a 4. And most of us have no problems with 4. I once told my partner that I would be glad to stage 1s, suspected deep tissue injuries, 4s, and unstageables if she would just do 2s and 3s. But she wasn't stupid, didn't sell it. Let me go back here. Here you have bone. Here you clearly have muscle. I'm going to come back to this point, but I'm going to make it now. Even though there's eschar in this wound bed, I can identify muscle. I already know it's a 4. It doesn't go any deeper than that. I can stage it. So guidelines for accurate staging, you base your stage on the viable tissue in the wound bed. If the entire wound bed is obscured by necrotic tissue, you can't stage. You have to say it's unstageable. But again, if there's any muscle, tendon, bone exposed, you can go ahead and stage. I think you probably all know not to reverse stage a healing wound. Like if it starts out as a 4, and the next week or 2 weeks later it's filling in with granulation tissue, it's a granulating stage 4. It's not a stage 3, because it's never going to have fat in that wound bed again. And if you say it's a stage 3, you're saying now there's healthy fat in the wound bed. No, it's a granulating stage 4. Back to my point, if the wound is partially obscured by necrotic tissue, but you can identify tendon or muscle or bone, you can go ahead and stage. If it's totally obscured, you have to label it unstageable until you can determine the type of tissue in the wound bed. Now, I'm going to spend our last few minutes just talking about strategies that will help improve accuracy in assessment and documentation, and ultimately will improve your wound care because it will focus everyone's attention on that critical question, is the wound improving? Helps to have structured assessment forms. I'm sure that most of you now have electronic medical records, and so you have drop-down menus. You want to make sure that your drop-down menus capture all the critical parameters. I'm going to share with you one thing that I've noticed missing in a lot of electronic systems, and that is the category of clean but not granulating. I've seen a number of electronic medical record systems that give you the opportunity to document slough, eschar, granulation tissue, epithelialization. But there's no category for clean but not granulating, which means there's a whole bunch of wounds that I cannot accurately, present within that electronic medical record. So critical to make sure that your drop-down menus are comprehensive and that they allow the staff to capture the key parameters associated with that wound. There are some validated tools out there that allow you to generate a numeric score related to wound status. Probably the most widely used is the PUSH, Pressure Ulcer Scale for Healing, but it's actually been used in other types of wounds as well. It's based on overall surface area of the wound, which is length times width, on the volume of exudate, and on the type of tissue in the wound bed. So it's a quick and easy calculation to do, and in some agencies they'll do the PUSH, they'll generate a PUSH score once a month or on admission and discharge to show progress in wound healing from a numerical perspective. There's another tool out called the Pressure Sore Status Tool, or now it's got pictorial guidelines, and it's called the BWAT. It's the Bates-Jensen Wound Assessment Tool. So there are some structured tools out there. They do take a little bit longer because you have to, fill out the form, do some calculations. You want to make sure that whatever system you're using, your staff understands the system and that they complete all of the critical fields. In some agencies, what they do is they have the staff document volume of exudate, overall appearance of the wound and the peri-wound skin at dressing changes. And then they have a member of the wound team or one of the skin wound champions do the in-depth assessment that should be documented once a week. Because it's much easier to take a small group of people and keep them very current and make sure they're doing it right. That's much easier than trying to teach every single nurse in the agency. So think how you're going to do that. Who's going to be responsible for doing that in-depth weekly documentation? And then you're going to focus your education accordingly. Now, what about photo documentation? A lot of controversy over the years, kind of a pendulum swinging back and forth. There are definite pros to photo documentation. It's true that a picture is worth 1,000 words. If I said to you, do you want to see a picture, do you want me to tell you about it, you'd probably say, show me a picture. Many times when someone calls us and they're telling us about a wound or a stoma or whatever, we'll say, do you have a photo that you can send to us, a digital photo? So very helpful, does support written documentation and gives, I think it gives more clarity as to what's going on with the wound. We've used it a lot for patient education. I've used it to say to a patient, look, this is your wound last week, this is your wound this week, to reinforce when they're doing things right and to alert them when I'm concerned and they should be concerned. You can also use it for staff education. And especially for ulcers that are present on admission, it really provides you with legal protection. Now, there's some cons as well. Sometimes risk management does not like for you to photograph wounds that develop in-house because they feel like it increases your litigation risk. Attorneys tell us that if there's not a picture of this one, they'll go get a picture. And of course, families take pictures all the time. So that mindset's shifting a little bit. But here's the other thing you have to think about. If you do move ahead with photo documentation, you want a very clear-cut policy and procedure. You've got to address storage. You've got to address patient consent issues. You've got to address issues related to technical accuracy, which is, are you taking the picture from the same distance with the patient in the same position? How can you tell that this photo is of this patient's wound? So there has to be some kind of identifying information in the photo itself with date, medical record number, location of the wound, whatever. Your goal is to avoid including in the photo anything that would identify the patient, if you can, like a tattoo or whatever. You have to look at how these digital photos are stored and attached to the record. Lots of issues. There's also infection control issues because this camera is going to go from room to room or house to house. So you really want to work with a team if you decide to do photo documentation to put together a comprehensive policy and procedure and to teach people how to do photo documentation correctly. And there have been some good articles written with wonderful guidelines that you could use as the basis for your policy and procedure. So here's some of the things that I was just talking about. I should have changed the slide. Most people put a measuring tape right underneath the wound so that you can show this photo was taken this day of this location of this patient, okay, and all the things that I said you need to address. So in summary, assessment is the baseline for your whole management plan. You want to do a really good job of it and you want to document it. Your initial assessment should address etiologic factors, systemic support for healing, wound status, and impact on the patient. Follow-up documentation primarily focuses on changes in wound status that would affect therapy, whether or not the wound's on track, deteriorating, plateaued. And in each dressing change, staff should document that the dressing was changed per orders, per protocol, that there was this much exudate, that the wound looked like this, and the peri-wound, showed no signs of infection, or there was newly occurring erythema and induration in the peri-wound area, and the wound care nurse and physician had been notified. Okay, that's it. Thank you very much.